Bye.
Hey everybody, welcome to Knock Knock Eye with me, your host, Dr. Glaucoma. This is your one-stop shop for all things eyeball related. And before we get into the eyeball stuff, because I got a lot of eyeball stuff for you, we're going to talk about a couple of patients from the Pitt, because I'm telling you, the Pitt is the content gods just keep giving me Pitt stuff. They're going hard. I think the writers of the Pitt or somebody in the Pitt maybe is a fan of mine, because they keep having eye patients on, which I love. I'm a big fan of that. So I get to talk about a couple of them with you. And also I have a mystery patient to talk to you about somebody I saw in clinic recently. But before we get on all of that, I just put the episode out, I think maybe last week or the week before, where I talked about hyaluronic acid injections, filler, basically, in the penis to help you in the Olympics. So thank you for the comments. Some of you were quite disturbed by this topic. I had a couple of great comments. I just want to mention this. At Tarzan's mom, Dr. G, what a scandalous title. The title of the episode, Can Penis Size Really Affect Olympic Performance? I think it's very descriptive. I think it's accurate, an accurate representation of what I talked about in that episode of Knock Knock Eye. At Neff Snicker said, Doc Glock wins the gold medal for the most times I've heard the word penis in a podcast. Fair. And I work in sexual and reproductive health. So that says something. Well, I'm not going to go into more depth about it. I did think about, like, maybe I could brainstorm, like, what are the other sports that can be aided by your penis in the Olympics? I wasn't really able to come up with anything. I'd be curious. Honestly, I only think like the penis could hurt you in the Olympics, like it did with the pole vaulter. Like same thing with like the high jump. I don't know. Could it slow you down? Maybe with the shot put or the discus in the Summer Olympics, you can't get you can't rotate yourself fast enough, because if you have a large enough penis, then the centripetal forces could make it to where you can't, kind of like a figure skater pulling their arms in. Like the tighter you get toward the center of your gravity, the faster you can spin. Well, is it the opposite? If you have your package is a little bit too large, it decreases your ability to spin fast enough. So it could affect you negatively in figure skating or like shot put, hammer throw, that kind of thing in the Summer Olympics. I don't know. I think it warrants discussion and potentially even some an academic study. Isn't this what academics is for? Like what else? What are you doing in the universities other than stuff like this? Like this is what people want to like. Put this on the cover of your journal, and you'll sell some journals. Like that's what I'm saying, right? Everybody's worried about nobody paying attention to reading research articles anymore. Talk about how the penis could negatively affect you during the Olympics. It's not that hard. Not that hard. No pun intended. All right, let's move on. We've talked about this enough for the last few weeks. The Olympics are over. We'll see you in 2 years for the Summer Olympics, which I enjoy more than the Winter Olympics. I'm not a winter sports guy. All right, let's talk about the Pitt. How about that? So again, we had, I have not caught up on all the episodes. And in fact, these two things, I have not seen the episodes that these patients are involved. I'm not giving any spoilers except just to talk about two patients that showed up on the Pitt that are relevant to ophthalmology. An ophthalmologist has not, I don't think an ophthalmologist has actually come in to see a patient in the emergency department, which is true to form. That's you're trying to make as accurate a medical show as possible. You're not going to have an ophthalmologist just hang out in the emergency department. It's a scary place for us. We don't like being there. That's it. I have the utmost respect for my emergency medicine colleagues because they see these patients and I don't have to most of the time, unless it's a pants patient. So anyway, the two patients on the Pitt, the first one was a conjunctivitis specifically, and I guess you could skip ahead if this matters to you. You don't want to be spoiled. You don't want to hear a spoiler about an eye patient that was on the pit. It's not really central to like any of like the ongoing storylines or anything. So anyway, I'm going to talk about it now. So the first patient had gonococcal conjunctivitis, the most feared of all the conjunctivitis. Actually, I don't, in my mind as an ophthalmologist, it is not the most feared of conjunctivitis. I hopefully will never end up with gonococcal conjunctivitis. If I do, I need to have a serious conversation with my wife. I don't anticipate that ever happening. Um, but what does scare me as an ophthalmologist is adenovirus. So let's just talk briefly about the different types of conjunctivitis, infectious conjunctivitis, I should say. So you separate them out into bacterial and viral. Bacterial conjunctivitis is one of the most obvious things you can diagnose. All right. It's not going to be subtle. You will have copious amounts of discharge. And it's goopy, it's gross, it makes you like not want to go near the patient, that kind of thing. Um, Easy to get a swab so you can send it off to culture, and then you'll have your answer of what bacteria is causing it. Um, in the case of gonorrhea, it causes what we refer to as hyperacute conjunctivitis. So whereas your run-of-the-mill bacterial conjunctivitis caused by like a staph infection or strep, usually it's staph, you'll start getting discharge, but it could take about a day or so. With gonorrhea, it happens very quickly. Within 12 hours, you are completely inflamed. You've got purulence pouring out of your eyes. You're irrigated out. Within an hour, it's back. Like it's that quickly. Sometimes even faster than that. So it is. It's not. The point is, it's not subtle, as opposed to viral conjunctivitis, which is the eyes. You look at the eyes; they're beet red. Bacterial conjunctivitis, often the eyes are not as red as you would expect. All right. The patient might not even be that bothered by it from a pain standpoint. Obviously, no one likes goopy eyes and blurry vision and all that. But as far as pain goes, we usually see worse pain levels with a viral conjunctivitis. And one in particular that is quite painful and miserable for the patient is adenovirus, which causes what we call epidemic keratoconjunctivitis. One of the most contagious things on earth. It's so easy to spread viral conjunctivitis. But patients don't have as much discharge. Their eyes are beet red. They're miserable. I've had patients crying in my clinic. The only things that cause people to be able to like cry because of pain are severe viral conjunctivitis like adenovirus, corneal abrasions, angle closure glaucoma. Like those are the big three of things in your eye that make eye diseases that make patients weep, tears of pain. And so those are your two basic categories of like viral versus bacterial. So you want to try to, when you're seeing a patient with conjunctivitis or pink eye or eye discharge, that's the bucket you're trying to put people in. And the reason I'm scared of viral conjunctivitis is because it's obviously very uncomfortable. It's incredibly infectious and can be for like a solid week. So you are out of work. You're not around people for a whole week. It really screws up your life. But also, I have seen, and there's case reports of this. I saw this in residency where the virus can actually track centrally and cause encephalitis. I have seen that. Started out as rip roaring, awful pink eye viral conjunctivitis caused by adenovirus that spread to the brain. That's bad. That's bad. Don't get me wrong. Gonorrhea is also bad, but that's now we're talking potentially life threatening. So, but on the pit, this patient, it was a pretty decent patient presentation. It was interesting because it was a nun. But the the only like nitpick I have about what the patient looked like is the discharge on this patient was a little bit too far inferior. Like that discharge is coming from the eyeball, basically, like right there on the eye. All right. But the discharge in this patient, it was like you could tell they were trying to show that there was a bacterial conjunctivitis, but all of the discharge was like down below the lower lid. And it was like it clearly like none of it was coming from the eye. That's the only it's small nitpick that I have to do as an ophthalmologist. It's my right. I deserve to do that. But so I was able to overlook it. It's fine. But discharge just wasn't in the right place. It needs to be right on the surface of the eye, basically. I'm not sure how you do that from a movie magic standpoint, but I'm sure they could have figured it out. So what do you do? What do you do about gonorrhea conjunctivitis? All right, so first is making the diagnosis. Like I said, the amount of discharge and the history is really important, right? So if someone has gonococcal conjunctivitis, there's a decent chance they have urologic symptoms, pain with urination, or sores, or some other indication that there's a sexually transmitted infection going on. Because that's how you get this, right? It's going to be contact with the genitals, that you rub your eyes, whatever, you get something in your eye, gives you the disease. And so you can obviously send a sample for gram stain. You get gram negative a diplococcus on the gram stain, and then you have your diagnosis. And so how do you treat it? So if I saw this patient in my clinic, I would send the patient to the emergency department. And the reason for that is because you need topical treatment, obviously, to treat the conjunctivitis, but for gonorrhea, you also need oral treatment. And there's also public health concerns when a patient has gonorrhea because it's obviously very infectious, very contagious. And so you want to be treating the patient, you want to be treating the partners, and the treatment. And it's not just like prescribing an oral medication. The first line treatment for gonorrhea is ceftriaxone, which is a medication you deliver via intramuscular injection. So, and also these patients will need some irrigation. We can do that in the eye clinic, obviously, but I would send this patient just across the street from my office over to the emergency department to get their treatment. So yeah, systemically, IV, IM, ceftriaxone. For the surface of the eye, we would treat with a topical fluoroquinolone. So our go-to for any severe infection of the eye, whether it's the cornea or conjunctivitis, is going to be moxifloxacin or ofloxacin. So ofloxacin, I think that's I want to say second or third generation, moxifloxacin, fourth generation. They're both very effective, broad spectrum. Remember, for the surface of the eye, we're not so worried about resistance, right? Because it's very localized, and as opposed to your systemically, which can end up with more severe sequelae from an infection. And so we really want to hit eye infections hard with broad spectrum antibiotics. All right, there's not that many antibiotic choices out there for the eyes because they're the ones that we have are effective. So the resistance isn't a concern, and so we're not having to continuously come up with new and stronger topical antibiotics because what we have works. Obviously, treat the sexual partners. These patients, because they have so much discharge, often need irrigation like 4 times a day, just regularly saline irrigation. Just get all that crap out of there, and usually recover from the conjunctivitis pretty quick once you start topical antibiotic treatment. So Cipro, moxifloxacin, ofloxacin. I'd probably go with moxifloxacin. Just the more miserable the patient looks, the worse the infection looks. I don't need a lot of motivation to go to moxifloxacin. My favorite. I love that eye drop. It's a good one. And then see the patient back a couple days, make sure the sexual partners are getting treated, and there you have it. That's your gonorrhea conjunctivitis. All right, let's take a break and we'll come back with the other patient that we saw on the Pitt. Hey, Kristen.
Yeah.
Be honest. Do people think about their eyelids?
Honestly, I don't,
Okay.
unless something's wrong.
They should, because eyelids are amazing. They distribute your tears. They protect you from incoming objects. They're really important for overall eye health as well.
And we both know they can also be affected by something very common, Demodex mite.
Oh, yeah. Demodex blepharitis. When
That's right.
Demodex mites overgrow and they start causing problems like itchy, red, irritated eyelids with crusties.
Collarettes.
Collarettes, you got it. And everyone should know that if your eyelids aren't healthy, your eyes won't be either. That's why it's important to see an eye doctor, to get an eyelid check, which is part of a normal eye exam.
And the good news is there's a prescription eye drop treatment available for Demodex blepharitis.
It's great news. To learn more about eyelid health and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. Okay, next one's a classic, and that's super gluing your eye closed. I've talked about this on the pod. There's a bit of this always like freaks people out because like, oh my God, my eye is glued shut. And often people think that what that means is that the eyelid is literally glued to the eyeball. That is not what happens when you glue your eye shut. So first, how does this even happen? Well, some genius decided that super glue containers, at least some of them, should look like eye drop bottles. And often people who use eye drops don't often have the best vision. So you can understand how someone might open a bottle thinking it's their eye drops. Turns out it's super glue, and bam, there you have it. Super glue to the eye, can't open the eye. And it burns like hell. So the first thing I tell patients is, and I'm telling you all now because it's just preventive. This is like preventive medicine for ophthalmology. Don't keep your super glue and your artificial tears in the same place. Separate them, please. They don't all go in the same junk drawer. We all have a good junk drawer. All right. Don't put your eye drops with your super glue. And this won't happen. This will not happen. Now, I've seen it once as a prank. That's a separate issue. That's like, don't do that. That's terrible. So what do you do? And the patient comes in, they're freaking out. They got, first of all, you can tell them your vision's going to be fine. In fact, not the same formula, same type of thing, but we use glue on the eye. So putting glue, even the strongest glue possible, like you're not going to go blind from it. You're going to be okay. You might get yourself like a nice little corneal abrasion, which will be quite painful. But the biggest concern for people is my eye is shut. I can't open it. Is it permanently going to be like this? No, of course not. But it's not your eyelid glued to your eyeball. It's the eyelashes, your upper eyelashes that are glued to your lower eyelid. That's what's keeping your eye from opening. All right. The glue is not, it doesn't have a dry enough surface on your eyeball to be able to like actually form an adhesion of the eyelid to the eyeball. But you can do that obviously with the eyelashes down to the lower lid. And so what do? You cut the eyelashes. That's all you do. Opens the eye right up. You might have to pry it open just a little bit, but it'll open. It'll open just fine. Trim off those eyelashes. Yeah, the person might not be happy with losing some eyelashes, but guess what? Within a few weeks, they're going to grow right back. All right. When you try to regrow a cut eyelash, it takes about 2 weeks. Regrowing an eyelash that's been plucked from like the follicle takes about 6 weeks. So it'll grow back. You'll be fine. And, then you treat any kind of, if there's an abrasion, you treat that and patient's good to go. So I encourage more. I want like a Pitt version. Like let's have the Pitt spinoff that just takes place in Fast Track. How about that? That might be interesting to only me and other people like me who have a strong affinity for eyeballs, because that's where all the eyeball stuff goes. It's like the Fast Track folks. But I would love to see that. We could see some angle closure glaucoma. Do some lasers. How about that? How about an extraocular muscle entrapment case? Yeah. Yeah. I'm feeling that. Have someone come in, have the ophthalmologist actually come in. We need a pants patient so we can actually see the ophthalmologist, see them show up with their luggage looking scared. I would, oh my God. The minute that happens, I'm flying down to LA and I'm personally thanking the people that work on the show if they'll let me in. Because that would be phenomenal. Let's do it. We need more. I guess what I'm saying is we need more ophthalmology representation in media. Not enough. Not enough. Not in Hollywood. Come on. In fact, I'm trying to think. There's been a lot of doctors in media. Do we have any ophthalmologists? Do we? There was an ophthalmologist that showed up, I think, in 1 or 2 episodes on ER. Noah Wiley's first show. But I can't think of like a famous ophthalmologist that's been like featured as a recurring character in TV or movies. If you can think of one, let me know. I'm very interested in this. I think most people just don't really know what an ophthalmologist is. They think we're optometrists. You know, to I'd say a vast majority of people, because I talk to them in clinic, they honestly they think we're just all one person, the eye doctor. So I don't know. All right. Speaking of clinic eye doctors, I did see an interesting patient. So I'll tell you about this case that had come in. I think what's interesting about this mostly is the pathophysiology. So this is a patient that actually came in for just a routine exam. So I had been seeing this person for several years. Their history, I would say 75 years old. Their history is about 10 years prior, they had had a central retinal vein occlusion. So central retinal vein occlusion, the central retinal vein is the largest vein that carries blood away from your eye. You know, it kind of grows right next to your optic nerve out the back of your orbit and drains blood that way. So when you have a central retinal vein occlusion, what happens, and this is common in people that have diabetes, that's the biggest risk factor for a central retinal vein occlusion, is you have one of the arteries in the back of the vein one of the arteries in the back of the eye crossing over a vein, in this case, the large vein. And when that happens, blood gets stopped. It can't leave the eye. So you get blood backing up, just like a dam, right? The arteriole is the dam. You're backing up the blood, and you get this like just really dramatic appearance to the back of the eye, what we call blood and thunder, because you have, first of all, a lack of blood flow. The blood's not going anywhere. It's just stationary. And so you get swelling of the retina in a form that we call cotton wool spots, which are basically little areas of ischemia in the retina that causes it to swell. They look white. I guess that's the thunder. And then the blood is, you get the backup of blood, which shows up as diffuse retinal hemorrhages. Eventually, the all that stuff clears away and you restore blood flow. Really, you don't even do anything. It just the body will work itself out and restore normal blood flow. But by that point, the damage has been done. With a central retinal vein occlusion, you usually have pretty massive vision loss. So that was what had happened to my patient years ago. Nothing really to do. The patient had count finger vision, so that all they could see was like, counting fingers in front of them, and have been doing okay. Lost to follow-up though. So I had not seen this patient for a couple of years. But these types of patients, typically you need to see them once or twice a year at least, because one of the risk factors of this disease, of having had this, is the eye is chronically ischemic. And when you put something in a chronically ischemic state, then you can start developing some abnormal blood vessels, just like diabetes. That's why you get neovascularization with diabetic retinopathy because the eye is chronically ischemic. And so it tries to make these abnormal, wispy little blood vessels that are prone to bleeding and causing all kinds of problems. Similar type of thing, slightly different mechanism of action or pathophysiology, but the eye is ischemic. And so what can happen, this is probably the worst outcome you can get from a central retinal vein occlusion, is you can have these abnormal blood vessels that start growing. So this patient just came in for a routine exam, checking the vision, checking the pressure. Vision's the same, still count fingers. That eye is essentially, it doesn't even use it. But the pressure was 55. Normal pressure, less than 20. This is not great, obviously. So the question is, okay, first, what's causing this? And when I looked at the front of the eye, I could see abnormal blood vessels growing on the iris inside the eye, what we call neovascularization of the iris. So not only can you get neovascularization in the back of the eye, but it's most of the eye is ischemic here in this situation. And so you can get neovascularization, abnormal blood vessels growing in the iris. And those vessels can also grow in the angle of the eye, which is where your drainage system is. And what happens when you have, well, first you can get big episodes of bleeding because those vessels, again, they're prone to breaking open and bleeding. You can get hyphemas, you can get vitreous hemorrhages. But what comes with these abnormal blood vessels is contraction. You know, so in the back of the eye, you can get these tractional retinal detachments as the extracellular matrix and connective tissue that comes with these abnormal blood vessels. It moves, it contracts and causes scarring and rips things open, rips the retina open. Well, when that happens in the angle of your eye where your drainage system is, those blood vessels contract and pull the angle closed. And what happens when you plug a drain? The water level starts to rise. But what happens if the water has nowhere to go? The pressure rises, and you end up with what we call neovascular glaucoma. So this patient who had a pressure of 55 had neovascular glaucoma. Those abnormal blood vessels had zippered up most of that angle. Okay, so on a scale from 1 to 10, how bad is this disease? Neovascular glaucoma is as bad as it gets. It's a 10 out of 10. This is one of the hardest things to treat in the world of glaucoma. Often, you cannot open that angle up. You can try. So you can give, one thing we would do is give injection of medicine, anti-VEGF, which can shrink those blood vessels and potentially open up the angle. But that takes too long. And so let's say this patient had a 20/20 vision, perfect vision, and they had something cause them to have neovascular glaucoma. Well, yeah, you'll give them that anti-VEGF and medicine, but it's going to take way too long to open the angle and get the pressure down. Even with drops, there's really only so much you can do. You got to get the pressure down. Otherwise, pressure stays at 55 for too long, for a few hours, you're going to start getting vision loss. And then by 12 hours later, patient's blind. And so you got to get that pressure down as quickly as possible. You give them drops, obviously. You're going to do that. You're going to give them the anti-VEGF, but you got to give the eye somewhere to put that fluid. And so you end up going for emergency surgery. This is one of the few, like, kind of more emergent, it's not like pants patient emergent. It could be, especially if it's an eye with a lot of vision potential. Like they have we could still save this eye type of situation. Then yeah, you might be going for urgent surgery. And I'm not going to go into details of that, but basically it's like putting a tube in the eye that allows for the fluid to drain via this tube as opposed to the normal drainage system, which is, again, plugged up, all closed up due to the neovascularization. Now, are we going to do that for this patient? Well, that's a conversation I have with the patient because, remember, There's no vision potential here. The patient, not even bothered by it. What that tells me is that this eye has probably had a high pressure for quite a while. If you or I, who have normal eyes, normal healthy eyes, all of a sudden had an eye pressure at 55, we'd be throwing up. We'd be in severe pain. We'd be on the floor crying because it's so painful. But when you have a sick eye already that doesn't see well, that's been had slowly, it's kind of like boiling a frog, like, the water, the pressure slowly been building. Often they don't have pain. And so the only reason you would want to treat that high pressure is if the patient has potential to see. But this patient had already lost their vision from the central retinal vein occlusion years ago. So you have a conversation with the patient and be like, well, we could treat it. This is what it would take to treat this disease to get the pressure lower, but it will not improve your vision. And 99 times out of 100, the patient's like, it's okay. And then at that point, what you're doing for that patient's eye is the ophthalmology equivalent of comfort measures only. We're just making sure that eye is comfortable, that the eye is not causing them pain. If the eye is causing them pain, then you treat, and you try to treat with as little intervention as possible to get that patient comfortable, because you want the eye to be comfortable. And sometimes with a blind, painful eye, you end up having to just take the eye out. Now, I don't think this is going to happen with this patient because he's doing just fine. He's doing fine. But so that's an example of a disease, neovascular glaucoma, that sometimes can be a kind of a pants patient situation. High pressure, angle closure glaucoma. It's a form of angle closure glaucoma. We have established that's a pants patient. I'm putting my pants in. I'm coming in to see the patient. But in this particular situation that this patient is in, it's not a pants patient. It's not even something we really treat. We're going to make sure the patient is comfortable. So there you have it. And that's our episode of Knock Knock Eye. That's all I got for you. So we did neovascular glaucoma. We did super glued eyelid, being super glued shut. And we did gonorrhea conjunctivitis. Man, we covered a lot in this episode. So thank you to my executive producers, Aaron Courtney, Rob Goldman, and Shanti Burke. Editor, engineer, Jason Portiza. Our music is by Omer Ben Zvi. I'm Dr. Glaucom Flecken. We will see you next week, everyone.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.